right, good morning, and thank you for the opportunity. All right, so aortic dissections, we know that they start with an intimal tear preceded by medial wall degeneration or cystic media necrosis. It's often associated with then separation of the inner 2/3 and the outer 1/3 of the aortic wall, resulting in circumferential and or longitudinal antegrade or retrograde propagation of the intramural hematoma. This creates a new space that we refer to as the false lumen. If you have an aortic dissection without an entry tear, we refer to that as an intramural hematoma, and I won't be discussing that. The most common location of the entry tear is between the aortic root and the proximal 1/3 of the descending aorta. In type B aortic dissections is often 2 centimeters distal to the left subclavian, and that's where the change in the forces and the pressure are the greatest, and that's why we see that as the entry tear in the type B aortic dissections. Here, because of our limited time, I've just included some pictures of classifications of aortic dissections, including the newest reporting for aortic dissections, not only including the origin of the entry tear, but also the distal extent. So that way we can have a common language when we talk about these problems. The degree of changes are dependent on the extent of the wall involvement, right? So you have hydrostatic pressure in the aorta wants to be equal. The true lumen is more rigid, whereas the false lumen has more mural elastin and collagen, and as a result has increased recoil. As a result, in order to maintain the same wall tension, this has increased filling and increased pressure, and as a result, this often results to compression of the true lumen. In the chronic phase, the false lumen becomes histologically indistinguishable from that of an aneurysm. You get attenuated wall components, and that's why you have this long-term wall degeneration and rupture risk, which is what has changed the paradigm of how we treat these and approach these problems. Ischemic complications, so if you have a type B aortic dissection, oftentimes is associated with a mortality rate of up to 25%, and this then doubles if you have an ischemic complication. Arterial obstruction can be classified in a variety of ways. You can have static, so with that dissection, that plane affects that aortic branch. That is a static obstruction and can cause ischemia. You can also have dynamic obstruction, so that doesn't necessarily mean that the dissection plane affects the aortic branch, but that the actual septum is coming in and out of that aortic branch, causing intermittent obstruction. You can get a combination of the both. You can also have ischemia due to embolic events, thrombotic events, and then, as I'm sure will be mentioned later, you can have ischemic complications due to the effect of an ascending aortic dissection with AI and coronary artery ischemia. Medical management has been for a long time the predominant way we manage type B aortic dissections. You want to reduce the blood pressure, but we want to maintain end organ perfusion. So these are some of the parameters that we aim for. The first-line therapy is beta blockade, oftentimes labetalol. That being said, please make sure your patient's not on cocaine, because then you're going to have essentially a massive alpha stimulation. You also want to treat these patients' pain. They come in with pain. They have sympathetic activation, so you want to treat those patients in a multimodal manner. The reason why that dissections are oftentimes our nemesis as interventionalists there are no two aortic dissections are the same. So it's incredibly important to have high quality cross-sectional imaging. Why? What are we looking at? We're looking at contrast extravasation, contained ruptures. You want to identify and understand the relationship between the true lumen and the false lumen. You want to appreciate the extent of the dissection, the location and the size of the intimal tears, the relationship of that flap to the aortic branches, and then you can also see findings that are consistent with malperfusion. So for a long time, medical therapy has been the standard. However, we know that there's about a 15% risk of an uncomplicated type B aortic dissection becoming a complicated aortic dissection in the acute period, so within the first 14 days. So that's why it's important to monitor these patients closely and to get surveillance imaging. In general, the complication or the mortality rate of patients who are treated in a medical manner is about 10% in the first 30 days. Why is that important? Well, that's one of the reasons why we don't rush to open surgery. The risk of mortality in the first 30 days, if you were to do an open surgery on these patients with type B aortic dissections, approaches about 30%. So it's quite notable. And that's why, for the most part, we were focusing on medical management. That being said, we know that approximately 40% of patients that are treated with medical management for type B aortic dissections will require an aortic intervention. And so that's why it's important to surveil these patients. And this is also what has affected us and has made us look at these high-risk anatomic guided intervention guidelines. So standard, what we've been taught, if you have a complicated dissection for the findings listed here, you want to intervene on these patients with type B aortic dissections. However, now we know a little bit more. So we know if someone comes in, has a maximal aortic diameter of 4 centimeters in the acute phase, has a proximal entry tear of greater than or equal to 10 millimeters, has a false lumen diameter of greater than 20 millimeters, has free floating or circumferential dissection, or partially thrombosed distal false lumen, we may want to treat these patients in the subacute phase in order to prevent degeneration in the future. So open intervention, I mentioned briefly, within the first 2 weeks, high morbidity mortality. As you treat these patients in the chronic dissection, which is out of the scope of my presentation, it opens the morbidity mortality approaches that of an open repair. Things that we want to think about, particularly if you're forced to do an open intervention in the acute setting, is limit the amount of intervention you're doing. The risk of these patients of having spinal cord ischemia is quite high, and as a result, you want to think about CSF drainage, left heart bypass. Other open options are open aortic fenestration and branch artery bypass. So let's say you take this patient for an open intervention, things you kind of have to think about. You want to, oftentimes, because we know where that proximal tear is, you're going to be putting your clamp between the left common carotid and the left subclavian. So you have to think about that phrenic nerve, the recurrent laryngeal nerve. You need to excise that septum. You want to include all layers in the anastomoses, reimplant distal intercostals, like I said, to protect you from paraplegia. Minimize aortic clamp time, heparinize these patients, and perform permissive hypothermia. Endovascular interventions, we've kind of developed this within the last number of years. Not only do we want to do this to prevent the rupture that we talked about, we can often use that endograft to exclude the false lumen, promote thrombosis, and remodeling. You oftentimes want 2 centimeter seal zone if you were to do this for this purpose. But you can also use endovascular interventions to treat malperfusion. You can use an endograft, particularly for the dynamic obstructions, to exclude the false lumen. You can create a fenestration, and you could do branch artery stenting. So why do we want to cover the proximal entry tear? For reasons that I just mentioned. You kind of want to relieve the dynamic obstruction, and you want to promote remodeling of that aorta. The extent and the effect of this coverage, which is probably the nemesis, like I said, of all vascular surgeons, is usually dependent on the size, the number, and the location of intimal tears along the septum. It's not uncommon that you have numerous communications, and this therefore complicates the repair. In the 2-year follow-up of the STABLE trial, 74% of patients had stable or shrinking thoracic aortic segments around the graft. And we've noted that less progression of disease and survival benefit noted at the 5-year mark when subacute uncomplicated TEVAR and best medical therapy cohorts were compared. So this is new. We know that initially there was no difference at the 1 and the 2-year mark, but at the 5-year mark, the long-term mark, we see a difference and a survival benefit. So treating malperfusion all really depends on what the cause of that obstruction is. Is this a static obstruction? Is this a dynamic obstruction? We can use IVUS and hand injections. Oftentimes if you use the power injector, that pressure can actually alter what you're seeing and the dynamics of the flow. It also depends on the presentation of the patient. So for a static obstruction where a branch is involved, you oftentimes will use stenting, and an open potential bypass is also in your back, options of what you have. In the dynamic obstruction, your goal is to restore flow. So you want to address that mobile septum, and that'll oftentimes involve deployment of a proximal endograph. Once you do that, you have to do another angiogram, aortogram, and reassess your intervention. There are special circumstances, so you can have a collapsed true lumen, and that's not necessarily suitable for an endograph placement. And an option that you have is the fenestration procedure. You can create a tear in the dissection flap near the affected vessel with subsequent dilation with balloon angioplasty and/or stenting. That being said, it's important that if you are concerned about an aortic branch, you should identify that, cannulate that, and oftentimes address that with a stent before you do a fenestration, because this can unpredictably alter the aortic flow. Prolonged ischemia from a collapsed true lumen, for example, in this setting of a type A, it really depends on institution specific, but many centers will perform a fenestration prior to the open repair of an ascending aorta, and this is for patients who have prolonged ischemia. And the contraindications are mentioned here to doing that. So thankfully, Dr. Raven will be discussing this, but indications for interventions for chronic type B aortic dissections are as listed here. I've also included the predictors of late complications, including heart hypertension, age, aortic size, and presence of that false lumen filling. And so that's why if you're treating this in the subacute phase, a lot of these things matter, the aortic size and the presence of the false lumen filling. Some endovascular adjuncts that Dr. Raven will also be talking about are balloon dilation, which we're taught in the type B aortic dissection. You do not want to balloon that proximal segment because you're going to risk a type A aortic dissection, but in certain settings such as in the Knickerbocker or in the stabilized techniques, those are options. You can also do false lumen embolization, such as candy plug, coils, and occluder devices, and this is oftentimes more directed towards treatment of chronic dissections, but is an option that you have. So in conclusion, aortic dissections continue to represent one of the most deadly vascular pathologies. Treatment must be individualized, and we really do need further larger studies with long-term follow-up. Thank you.